So you study pain. Can you define it?
I can. In fact, I was on a committee that recently redefined it. In fact, at the end of the day, they went with my definition. So pain.
Congratulations.
Oh, I guess. I mean, yeah. So pain is a sensory and an emotional experience, either in response to tissue damage or resembling that.
Okay.
Associated with tissue damage. So the idea is that if there is something that is already or about to cause tissue damage, okay, or if it feels to someone as if that's happening, that's what pain is. And of course, that last weird part, if it feels like it, is in response to the well-known phenomenon of neuropathic pain, where there is no tissue injury. There might have been at one time, but there's no tissue injury now. But likely due to nerve damage, although only sometimes can we find the nerve damage, the patient has the same perceptual experience as if there were ongoing tissue damage.
Okay. And how prevalent is neuropathic pain in the population?
Well, neuropathic pain is much harder to decide on a number because it depends on what percentage of back pain you think is neuropathic. I can give you the number for chronic pain in general,
Sure.
neuropathic or otherwise, and there's been a lot of epidemiological studies that have basically consensus on this estimate. 1 out of 5 people has chronic pain right now. Chronic pain being defined as pain that has lasted 3 months or longer. And your lifetime risk of getting chronic pain is 1 in 2.
1 in 2. Okay. So lifetime risk, that means from like 0 to 80 around-ish.
From the time you're born to the
Yeah,
day you die,
okay.
your chances are 50% that you will have at least one episode of pain lasting 3 months or longer.
Okay. And so what are like the most prevalent forms of chronic pain?
Right. Number 1 is back pain. Number 2 is headache. And other types of musculoskeletal pain like neck pain, shoulder pain, that is very, very common. Of course, arthritis is very, very
Hip
common.
pain too?
Yeah, hip pain would be a part of the musculoskeletal. And of course, arthritis with increasing age.
Okay. So it's quite an umbrella term to a certain extent.
Yeah, and that's an interesting point because I think that's part of the reason why pain probably doesn't get the amount of attention or funding that it probably deserves, because a lot of these disorders have different names that don't include pain, right? So, headache and migraine and arthritis. And people sort of, because they don't have pain in the name, people were like, oh, those are different things. But are they different things? And of course, whether they're different or the same depends on how you want to deal with lumping and splitting. But I've always been a lumper, and I think different types of pain have more in common than they have differentiating them. And so it's probably appropriate, especially in terms of divvying up resources, to lump these things all together. And when you do that, you quickly convince yourself that chronic pain is the biggest human health problem. The only thing that even comes close in terms of prevalence and the amount of money it costs and the amount of suffering it costs is probably depression.
Okay. That was a lot of things. So you said that pain is underfunded to a certain extent.
Yes.
Can you dive more into that?
Pain, for example, and again, these are data from the US, and about 10 years ago, I really doubt anything major has changed. Pain gets about 1% of the funding of cancer. And of course, cancer is a terrible thing, and it kills a lot of people. It's the number 2 cause of death. But surely pain is worth more than 1/100th of that.
Right.
And again, the reason people don't take pain seriously is that they say, well, it doesn't kill you. First of all, that's wrong. It does kill you. It just does it slowly and indirectly. But the other thing I think that has been true for a long time is that people care very much about mortality, but they don't care nearly enough about morbidity. So as long as something doesn't kill you, it's thought to be not that big a deal, regardless of the immense amount of suffering some things can cause. And if you think about it for a little bit, you might convince yourself that morbidity is just as important as mortality, possibly more important than mortality.
Interesting. So, can you go more into morbidity? So, in the sense that you just mentioned that there is a emphasis on some type of post hoc treatment where it's like after the fact of someone's reporting pain. Are you implying that there should be an emphasis on preventative measures?
We don't have a lot of opportunities for prevention for pain, largely because pain and chronic pain are largely caused by accidents of one sort or another, right? Like actual car accidents or other sorts of injuries, or disease states that in most people heal up just fine. And for reasons that aren't completely understood, things go wrong with the resolution process in humans. So it's hard to do something about people getting in accidents. I mean, I guess there's something you can do, right? Better safety measures. There is one clear example of prevention for pain, and that's we can prevent most cases of postherpetic neuralgia, which is one of the most common forms of neuropathic pain. Because postherpetic neuralgia is a complication of shingles, and there's a vaccine for shingles. And so if more people got that vaccine, there would be a lot less shingles. And if there's a lot less shingles, there'd be a lot less postherpetic neuralgia. So that's an example of prevention. But prevention's tough for pain. And of course, that's unfortunate because treatment is bad for pain. Once you have chronic pain at the moment, there's not all that much we can do about it that's particularly effective.
Okay, so then how can someone with chronic pain mitigate, or not mitigate, but like buffer against that outlook where they're going to be dealing with that for like the rest of their life, presumably speaking?
I mean, there are things you can do about it after the fact. The classic example of that is that it's been shown with very, very strong evidence that exercise is probably the best, most effective treatment for chronic pain.
Are there specific types of exercise that are more beneficial?
I'm not sure anyone's got to the bottom of whether aerobic versus strength training is better. I think they're both good. But of course, exercise is something that people don't want to do, and especially they don't want to do it if they're in pain. And that is a lot of what pain psychology and physical therapy for pain is about these days, is trying to convince people that exercising will not make their back pain worse and actually will make it better. If you can get people over the hump, they find that it's very effective. It's very hard to get someone with back pain to consider starting an exercise program. And we're trying to figure out better ways to motivate them to do so.
Okay, so then that begs the question of, do physicians often prescribe exercise as a form of rehab?
Well, they're definitely starting to, and they're starting to be, as the appreciation comes more and more online that the standard pharmacological treatments don't work very well. And frankly, the standard psychological treatments don't work very well either. But of course, there's a difference between treatments without side effects and treatments with. And of course, we haven't given up on the pharmacological or the psychological treatments. There's plenty of work being done to come up with better analgesics and better psychological treatments.